very special occasion. I'm Rosemary Mackenzie and I'm the chair of the board of Peter MacCallum Cancer Centre. And it's my pleasure today to be here with you to officially launch the Peter Mac Centre for Health Services Research in Cancer. I would like to begin by respectfully acknowledging the traditional owners of the land on which we meet today, the Wurundjeri Woiwurrung people of the Kulin Nation. I pay respects to their elders, past and present, and acknowledge First Nations colleagues and friends who may be with us this morning. And I'd particularly like to note that it is NAIDOC week, and it's the 50th anniversary of NAIDOC, and the theme is Next Generation, Strength, Vision and Legacy. It's wonderful to see so many people here today, many familiar faces. Welcome to you all, and to the many people who are joining us online during school holidays, almost as many people online as in the room. I'm delighted to see that we are welcoming many partners of Peter Mac. Partnership is so important to what we do. I'd particularly like to welcome our colleagues from the University of Melbourne. I see there are many in the room, including the Dean of Medicine, Dentistry and Health Sciences, Professor Jane Gunn. Jane, thank you for making time to be with us today. Jane is shortly about to be interim provost of the university, so I'm sure that finding time to be with us today was a bit of a stretch, so thank you. Welcome also to Todd Harper, Chief Executive of Cancer Council Victoria, and welcome to our colleagues from the Parkville Local Health Service Network Services. I'm also delighted to welcome colleagues and collaborators from Monash, Sydney and Deakin Universities, Cancer Australia, and of course the Victorian Department of Health. Thank you all for coming on this journey with us. It's one that we've been on for a little while. Your support and collaboration will help us to build the impact of the Peter Mac Centre for Health Services Research in Cancer, not just for current patients, and I should also say welcome to the several consumer representatives who are with us today, for whom our work is, they are the most important people for whom our work is directed. And it's going to benefit not just current patients, but future patients and the health sector as a whole. This new centre represents a very significant step forward for us. We feel far beyond Peter Mac's boundaries, but for cancer care in Victoria, Australia, and hopefully across the world. It speaks to our commitment to not only providing world-leading cancer care and research, but to continuously improve our services and systems. Health services research is very much about strengthening systems and services. The centre also reflects our commitment to making cancer care safer, smarter, more equitable and person-centred. The team from the Peter Mac Centre for Health Services Research in Cancer have brought together an exciting program for us today. We'll soon hear from Centre Director, Professor Karen Thursky, who'll present our vision for what the centre will achieve. Consumer Representative Stuart Auckland, who will share his experiences and remind us just how important this work is for the people on whom it has most impact. We'll also have a health services researcher panel led by our Executive Director of Cancer Research, Ricky Johnston, and he'll be joined by Professor Thursky, of course, and a number of Peter Mac Health Services researchers, as well as Peter MacCallum Cancer Foundation Chief Executive Craig Connolly. And I'll note that Professor Belinda Campbell, our Deputy Director of Radiation Oncology, Belinda Lambros, Nurse Practitioner in Infectious Diseases and Antimicrobial Stewardship, and Jeanette Loeliger, Manager of Nutrition and Speech Pathology, will be the researchers that join the panel. And our Chief Executive of Peter Mac, Professor Jason Payne, who's with us this morning, will make the closing remarks for the day. It's a very diverse program, and we hope it will be a window into the way we are planning to approach our expansion and further integration of health services research within Peter Mac and across the sector. A number of you will know that I've spent much of my professional life in health services research. Who knew that the little girl would grow up to be a health services evaluator? And this work is particularly close to my heart because I'm very aware of the impact it can achieve. When we talk about improving outcomes, we're going well beyond clinical breakthroughs. We're talking about how health systems and services work, how care is accessed, how patients experience their treatment, and how we use our resources wisely. And the latter, of course, is very important. These principles are really the essence of what we call value-based healthcare. Many of you work in value-based healthcare. And this will ensure that the outcomes that matter the most to patients are delivered effectively and as efficiently as possible. I feel Peter Mac's uniquely placed to lead this kind of work. We have our famous bench to bedside model. I've heard Ricky speak of it many times, with research, education and care all here under one roof, that enables us to turn evidence into action quickly and to evaluate what works in the real world. Since 2020, under Kaz's leadership, Peter Mac's Department of Health Services Research has demonstrated just how powerful this approach can be. The establishment of a dedicated Peter Mac Centre for Health Services Research builds on this very strong foundation that we've had for 5 years and positions us to expand our impact, hopefully in partnership with many of you and your colleagues here today. I'd like to take this opportunity to acknowledge and thank the exceptional team led by Professor Karen Thursky, who've helped make this a reality. I know it's been a long-held vision, Kaz, and you'll speak more to that shortly. Health services research is inherently collaborative and it's multidisciplinary. It engages clinicians, researchers, allied health professionals, data experts, patients and policymakers. It spans diseases, methods, departments and institutions, and that is what makes it so powerful. As cancer care becomes more complex, more personalised, we hope more effective, we need to ensure that our systems evolve too. This centre will help us do exactly that. It will generate the evidence we need to design better models of care. It will support teams to embed research into everyday practice, and it will ensure that we continue to lead in delivering care that is coordinated, equitable and outcomes focused. We are very proud of what this centre represents and what we believe it will achieve. It's a tangible step in support of our vision to deliver fully integrated, personalised cancer research and care when it's needed, wherever it's needed. It's now my very great pleasure to introduce the Director of the Peter MacCallum Cancer Centre for Health Services Research in Cancer, Professor Karen Thursky. Welcome.
Thank you so much, Rosemary. And as we sit over coffee one day, you know, as one health services research for another, we need to help ourselves. So it is a great pleasure, and welcome everybody, and also welcome online. I think my mum's even online this morning. So welcome, Mum. I think we're incredibly fortunate to have the research structures that we have in this place. I would specifically like to call out Professor Ricky Johnson, our Executive Director, and my fellow Associate Directors who cover off laboratory science, translational, clinical research, health services and operational. Together as a research executive, this has been a plan in the making for several years, and I acknowledge the fact that while it was a bit of a learning curve in the first few years, they have really embraced it and supported, and I believe have embraced it within not only our research strategy, but also the hospital strategy, remembering that health services research is a key opportunity to actually optimise how we deliver high quality patient care. I'd also like to reflect our Chief Executive Officers, Professor Shelley Dolan, who was a health services researcher in the UK, and also Jason Payne, both of whom have been incredibly supportive of this vision because they see the opportunities it actually brings. And finally, the foundation. I cannot thank the foundation enough in how we are a very unique organisation where research is really first and foremost. So when I took on the role of Associate Director of Health Services back in 2020, mid-COVID, I'd already been at Peter Mac for over 20 years as an infectious diseases physician, working in health services research and digital health. I'd actually already worked with everyone, across the organisation, at Royal Melbourne, at the Children's, MCRI, at the university, and I immediately recognised that there was an unlimited potential to establish this world-class program. And we didn't start from nothing, actually. I was able to bring on board the Department of Cancer Experience Research, which had been established 15 years before. There had been overseen by esteemed researchers, Professor Sancha Randa and Mark Krishnasamy, and we transitioned initially to a department. And this is a tricky time in COVID where many of my team were actually working off-site, so it was extraordinary that we continue to push on through that period. I commissioned Professor Sancha Randa, who's a key policy expert in cancer, and Amelia Hyatt, one of our PhDs, who is a policy fellow, research fellow, to undertake a gap analysis across the organisation and to come up with an operational model of how the health services research needs to be established, understand the key priorities and where investment needed to happen. And during that period, I uncovered, of course, the unbelievable range of activities happening, not only in our organisation, but I understood very clearly that there were strong networks with our partner universities, some of who are here, and it's wonderful to see you, and also international relationships, which are incredibly important. And we have existing MOUs with key bodies such as the Christie, Princess Margaret, MD Anderson and other sites, which are going to be very important as we establish our vision. However, along that line, there were still many, many silos, and there was a widespread lack of awareness and understanding of what health services research is. Even today, there are still people who question what's health service research. But the best thing is that I get stopped in the lift now, I get stopped in the corridor by fantastic department heads and clinicians across the organisation saying, Kaz, I've got a great idea for a synergy grant, a CRE and MRFF. I really want to bring in some health economics and implementation. Can I come and talk to your team? And so that's where we've come from. But we're also fortunate to build on the strengths of discipline leaders such as Sancha, Linda Dennehy, Mike Sami, Michael Jefford, who are all recognised world leaders in this area. And very early on, we invested in implementation science, which is obviously our biggest gap, with the strategic appointments of Professor Jill Francis, who's actually here today, Professor Steph Best, who's online, and Dr. Lisa Gucciari, who's in Disneyland. And we had a talented pool of emerging leaders, including Carla Goff, Tim Spellman, and several others that provided that foundation to support the growth of the methodological expertise, which is so important. And I would like to extend my thanks again to my strategic development managers, originally Jo Phipps Nelson and Neil Lewin, have been so important in actually bringing this together and getting here today. So Peter Mac is actually uniquely positioned because we will be the only Centre for Health Services Research that's sitting inside a dedicated cancer hospital. And our vision to transform cancer care is going to be delivered through equitable patient-focused research. We really do want to be a hub. We want to be collaborative. We have existing relationships with the university, our precinct partners, that will make it really an exciting program of work to support the delivery of good patient outcomes and care delivery. But also, we're in a stage where we have now got the Australian Cancer Plan, the Victorian Cancer Plan, the Parkville Precinct Plan, the local area networks, the comprehensive cancer networks and various other cancer bodies. There is a tsunami of priority setting, metrics that we need to meet, and how do we understand how we're going to prioritise and deliver the most important piece of work. And I can give you a little example of how we used implementation science with Stephanie Best and our team to undertake a VCCC priority setting exercise where we established 4 key priorities for our clinicians across the VCCC. One of them was digital health, another one was engagement with consumers, another one was actually how to use genomic testing in routine care. And that's an example of prioritisation. Another one is funding that we've just got funding from the Leukemia Foundation to examine the implementability and acceptability of the optimal care pathway for leukemia. You know, we love these optimal care pathways, but how feasible, what are the challenges and what are the barriers for them to be implemented in an equitable way? We also need to change the way that we do research. Traditional research where we have clinical trials or knowledge-based single projects, eventually getting a result and thinking about implementation. These are slow and cumbersome ways to change policy and practice. And so we need to think differently. Not only does it lead to research waste, but it also delays bringing best care to our patients. We are embracing what we call the learning health system model, where we are going to use a data-driven approach to understand and visualise what is happening to our patients, bring in our implementation science and human factors experts to make sure that we understand barriers and what we need to implement effective models, and also to always consider evaluation of patient outcomes and feed that back to our clinicians to understand that we are going to have continuous program of improvement. This theory of change really came about from the work of Sancha and Amelia, but really on a page clearly articulates to us how we're going to focus on value-based care as well as learning health systems to take a data-driven approach to collaborate with our clinicians and bring that methodological expertise so that we can actually understand priorities of the organisation, priorities for our research strategy, to drive big grants and scholarships for our clinicians and our researchers, and do that knowledge translation piece and continually develop our program. So ultimately, we want to see a situation where not only Peter Mac, but all centres delivering cancer care consider carefully how they can embed health services research principles into their design to support their evaluation, and really think about standardising some of our definitions and data models so we can really start to bring together data at scale, not only just for our precinct, but Victoria and Australia. So what is it? What is our centre? Well, essentially we have an incredible group of clinician leaders, many who are in the room today, together with methodologists that can work with them. Our centre has 3 key priorities. One is the research, the second is education, and the third is career pathways. And all 3 are equally important. And we need to, and in fact, 1/3 of all research at Peter Mac at the moment is related to health services research. There is no shortage of opportunities and activities, and we welcome our collaborators to come in and build exciting new research projects together. The other important thing to say is that the centre itself has dual reporting, both to the operations Chief Medical Officer and also to the Chief Executive Director of Research, so that we're constantly prioritising and ensuring that both sides of the coin are supported. Coming back to Rosemary's comment about value-based healthcare, these are some of the known elements, of course, how to deliver patient-centred outcomes to make sure that the whole pathway and journey of the patient is catered for. And that includes things like primary prevention, secondary prevention, supportive care programs, as well as optimising surgical and chemotherapy and novel therapy delivery, shared decision making. I don't think we do well enough in integrating with primary care, and it is a major focus for us to bring that into place. Equity and access is an underpinning principle for what we need to do, and we know even now that we have major challenges with delivering equity of cancer care Australia-wide, and this will be supported by a model. But I wanted to just spend 2 seconds on patient-reported outcome measures. This is one of our shortfalls, I believe, both at Peter Mac, statewide and across Australia. Proms are important because it's a direct communication from the patient through to the care delivery, and we must have proms in place so that we can actually ensure that we're continually improving our cancer programs to support optimisation of care. And so one of our key priorities kicking off this year will be to establish a proms program here, optimising the use of Epic to deliver even real-time symptom monitoring to some key units. There's a lot of excitement and enthusiasm right through the organisation, and hopefully we'll be able to report next year on our progress. I could speak for 2 hours about some of the experts in the programs, and when you're out having morning tea, there is a slideshow that will be cycling through some of these programs, and hopefully put that video onto our website as well. But there are many experts, many are in the room today, that have been working and are leaders in this space, and actually it's very, very exciting. So you will start to see some major grant opportunities and research opportunities to join our teams working in this space, working to the future. This is my ChatGPT generated picture of the issue with data, which I totally love. You know, there is the Titanic at the back with the EMR, which we're constantly chasing, but that iceberg analogy is very important. Our clinicians are only using a tiny proportion of data to make their decisions, and there's a whole lot of stuff underneath the water, including a lot of qualitative data that is not accessible to them to make the decisions. There is still challenges with bringing data from patients in the community, as well as from primary care and other sectors, to actually inform our health services research. So data is the #1 priority for our centre. So thank you to Ashley, who is sunning himself somewhere and can't be here, but sends his good wishes. Ash has been working really hard over the last nearly a year, I think, to undertake an implementation and human factors approach to how we can optimise the use of data in our systems to help health services researchers and clinicians. And part of that was re-looking at how it can navigate. It's really hard to do research, and people get a little bit depressed at all the checks and balances and ethics and governance. We want to simplify and optimise the access to that data, and to have streamlined processes to support particularly low-risk pathways and quality assurance research. It's a really important thing, and that's what our researchers want. But also we need to provide a secure research environment, meeting our GDPR compliance, that they can access data and use it. And we have some great programs in place. I know BioGrid, Maureen is here from BioGrid, and there's some brilliant programs where we're really forging ahead with some amazing digital health applications. And as I said before, we need to we need to accept the fact that we need national data definitions and common data models, because we're never going to be able to move to that big data space where we can aggregate data at scale. Our digital capability is actually fundamentally important, of course, and we have been investing. We have 3 EMR data analysts so that people can actually come to our centre and get meaningful data that's curated together with clinicians. We are investing in clinical informatics, and hopefully we'll be having a clinical informaticist starting with us very soon. And we are sitting on an enormous treasure trove of incredible cohorts and registries and real world data that will underpin some of the opportunities that we can do. So second last slide, you know, where are we heading? We have had some amazing conversations through the foundation recently about precision cancer care as one of the other key priorities. We have got a long way to go, but obviously right at the very top is we do not want to create programs that are going to increase the gap in and inequity in delivering care if we're going to be fully going digital, because that does create bias. So we need to, at the front, consider our cultural and linguistic diverse patients, Indigenous patients, think about how we're going to incorporate this data. We have incredible initiatives at Petermat, particularly around genomics. We have not capitalised on data from both the community, and we have, as I said, we have some incredible real world data sets that we need to be leveraging and using, as well as the tissue specimens that come with them. My last slide is, I guess, a reality check as well for those of us who are health services researchers in the room who know only too well how difficult it is to get the prize investigator grants. It is a very sobering statistic that last year only 3.4% of investigator grants went to health services research when there were 174 applications. This is clearly not right. And so we are absolutely committed on building these career pathways that will recognise and support, sponsor these researchers too. And we have a MacTrack Fellow, Nicole Canane, we have Future Leaders Fellow, Belinda Campbell here, talking today. We've had Belinda Lambros, who is one of our Learning Health Fellows. But we also need to recognise that two groups which have been underserved in terms of research support and clinical pathways are our allied health colleagues and nursing colleagues, and you'll hear that on the panel as well. Finally, Peter Mac itself is an incredibly well-organised, well-oiled machine in recognising and sponsoring and our early career researchers. So the Discovery Fellowship program is really very important. But beyond that, I welcome the collaboration with our research partners that are here, because we want to have a two-way street here, bring opportunities because we have the patients and data, but also to share with you and bring opportunities for PhDs and other researchers. So I'm going to stop there because the next most important person is Stuart Ackland, who's come to us from Tassie. He's our consumer representative on our leadership team for health services research, and we're very honoured and pleased that you came across to talk with us, so thank you.
Thank you very much, Karen, for that lovely introduction. And yes, indeed, it's an honour to be here today and to be amongst such eminent people working in the field of research tool, yeah, is that better? Working in the field of research and clinical leadership. So I just firstly would like to express my sincere gratitude on the behalf of a lot of people like myself who are living with cancer for the wonderful work you do. And honestly, I wouldn't be here talking to you today if it wasn't for the work that you do. I am a patient of Peter Mac, who have recently had some treatment here, so I know firsthand the benefits of what you can do here. So thank you from the bottom of my heart for the work that you do here. So thank you. So what I'd like to talk to you today about is, as explained, I guess what I think is the importance. Let me put it a different way. The critical element of having the consumer input into research. My background, just by way of an introduction, I spent 22 years working as a researcher in preventative health at the Centre for Rural Health in the University of Tasmania. And I'm absolutely passionate about community input, consumer input into research. That was very much my, my main mandate for working. So I find myself now being on the other side of the fence, if you like, being someone who is, I guess, a beneficiary of that. So I think it's absolutely critical. So what I'd like to do today is talk about what I think, or why I think it's critical to have that input into research, and a bit about my experience on the Health Services Research Committee as well, and what I've gained from that as someone who is living with lived experience. So very quickly, my background, I was diagnosed with prostate cancer, stage 4, Gleason score 9, 3 years ago. I'm one of 72 people who are diagnosed with prostate cancer every day in Australia. My story initially wasn't particularly a positive one. I went on to hormone therapy fairly quickly. Chemotherapy followed that, and radiation. I went through the tiers of hormone therapy fairly quickly. Nothing seemed to work. My PSA would go down briefly for a while, and before I knew it, was back up again. And prior to being diagnosed, I should add that I consider myself an active, healthy individual, and I had absolutely no symptoms whatsoever of prostate cancer. It was just through a regular men's health check that my GP said to me, I think we better do your PSA check. I think it came in initially at 5.5, slightly higher than what it should be. He said, look, just to be sure, I'd like you to come back again and we'll do another check next week or in the next few days. So I went and had a blood check fairly quickly. In that short period, it went from 5.5 to about 6.7. So rapidly going up. So I quickly went through the whole process of oncology, scans, biopsies, etc., which then revealed that I actually had, at the time of the scans, my PSA had only risen to about 12.6, which, as you know, many of you work in that space, is relatively low compared to some of the presentations that you have. But the tumor load on my body was extremely excessive. In fact, my oncologist said, I haven't seen such a tumor load with such a low PSA ever before. So clearly my tumors were immature, but they were very aggressive. And as I said, I immediately went on to treatment. Whilst that treatment happened to decrease my PSA initially, it very soon came back up. So in around about, I think it was April 2023, I'd been through the second tier of hormone therapy that wasn't holding my PSA. My oncologist said, well, I think we may be looking at a second round of chemotherapy. I was very fortunate that I had maintained or established a very close contact, communication, relationship with the Prostate Cancer Foundation of Australia, who I must say at this point, I'm in extreme gratitude for the work that they do in raising awareness. They said to me, well, are you aware of the work that's been happening at Peter Mac? And I must say up until that point, Peter Mac, I vaguely heard about it, but I wasn't aware about what was done here. And they told me about some treatments and some trials that were happening over here. And they said, why don't you see if you can get yourself to get into Peter Mac to have that treatment. So I was fortunate. I went down to Hobart, had an FDG scan and a PSMA scan, and I was one in 3 people, I believe, were eligible at the time for the lutetium treatment, which was offered through here. I spoke to the specialists here, I had an interview with them. There were a few minor complications. My platelet count was excessively low, or quite low as per normal, but I was able through my GP to demonstrate that that low platelet count was historical and not necessarily due to the chemotherapy and the other treatment I'd received. And fortunately, I was accepted here as a patient for the lutetium treatment in I think it was June 2023, scheduled for 6 sessions of treatment. It worked so well for me. Fortunately, after 5 sessions, the specialist here said, look, I don't think you need to come back for your 6th session. So they let me go. Here I am, 15 months later. I now have a non-detectable PSA. It's been continuous for me. So I feel very honored. I know I'm sitting on a time bomb, but I'm here, and I guess this is partly a good segue as to why I'm here talking to you today. As I said, I'm someone who's very passionate about research. I'm also very passionate about consumer input into research. And when I came here for my treatments, I wandered around the building all in awe of everything that I was looking at. And I spoke to a few people about what goes on in this building, and they talked about the volunteer program through your consumer engagement team. And they said, well, why'd you go and talk to the consumer engagement team people about opportunities? I live in Tasmania, so that might have been problematic. So that's when I first heard about the Health Services Research Committee. And I thought, what a wonderful opportunity for me to get involved, because it kind of matches my skill set, my passion. I understand a bit about research, albeit not cancer research, but I understand research methodologies. I believe research is the pathway to hopefully solving a lot of our woes. So I applied to be on this particular committee, and I was very impressed with the processes that I had to go through for that. And fortunately, I was accepted. So that's really how I actually got onto the committee. So why do I think it's particularly critical as a consumer, as with lived experience, to be on research committees and institutions like this? Is because I think the voice of the consumer is absolutely pivotal to your research. And I've seen that, we've seen it. There's so much evidence, particularly around mental health studies, dependency studies, area that I worked previously in suicide prevention. It's a game changer in terms of how we design our research, how we implement our research, and how we report our findings. So I thought I could use this knowledge and get involved here and see how I can apply this in this particular context around cancer. So first and foremost, I think what lived experience brings to research is that clearly that voice of the consumer. We are living it. And there's this lovely mandate that I always remember in my head: nothing about us without us. And I think that's essentially my understanding of why it's so important, from the very part of designing, co-designing with consumers, through the way that your research or the research is translated back into the community. So pivotal. So I think that's clearly one of the main reasons why I think it's important. I think there's also some very strong ethical reasons why people like myself with lived experience should be involved in research governance structures. Mainly because if you think about the way that you go about collecting data, the way that you use the data, the way you design your instruments for collecting data, the way you report back, it really needs to be in a way that can be effectively understood and consumed by people like myself. I come from a state with very low health literacy, and I've seen firsthand what people can do when they're suddenly their life is turned upside down and they're diagnosed with cancer. They don't understand what the system is. There's research out there, and for many of them, it makes no sense at all. I'm privileged, I'm tertiary educated, I've been in the tertiary system, I understand research, so it works well for me. So I think really from an ethical point of view, and we talked earlier a bit about, and I'd love to see that equity, inclusion, and things like that. They are key themes that are so important when you think about doing your research. So it's been an honour for me to be part of the committee, because although I'm sitting in Tasmania, I feel I've been able to say a few things, and I also acknowledge that I don't necessarily represent all my cohort of lived experience men with prostate cancer. As I said, I'm a 65-year-old middle-class white male, reasonably educated or well-educated. So I understand that. I understand those issues about how that information and how those particular pockets of society can indeed miss out. I'm forever conscious about that. And because I live in a rural community, I'm also particular about how this information gets out into those in our community who are most vulnerable. So I feel in the time that I have left, I want to use this time as best I can with my knowledge and my skills to make a difference to people with prostate cancer, and indeed with people in cancer in particular. So really, they're the key issues there. I think it's so important, and you know, it's a no-brainer for many of us. But I think as we go about doing our clinical research, it's very, very easy to think about your target audience, those people that you're actually doing the research for. And I think just having someone with lived experience to ask the questions is so important in the direction in which that research takes. It can change directions completely. And for me personally, I should also say it's been incredibly empowering for me. It's helped me reflect on my own cancer journey very deeply. It's also connected me to a place like Peter Mac and the research that's done here. So again, I feel very, very privileged around that. So it's not without its challenges. And I should say, as was mentioned, I live in Tasmania. I have joined the committee online because that's really the only way you can. I'm now retired. The day I was diagnosed with stage 4 prostate cancer, my GP said to me, go and smell the roses. And that's exactly what I have been doing for the last 3 years. So I don't have the luxury of, I guess, the digital and the IT support that I used to get when I was at a university. So quite often I have problems, and those in the committee know there's been a few problems with regard to that. So that is one issue. The second issue that I do find challenging, and I'm sure other lived experience or consumer advocates on committees would probably share a similar thing. I sit down and I listen to the committee proceedings, and I quite often hear a lot of acronyms going around. I'm not familiar with the governance of this organisation, so there's a lot of stuff that, even though I have a basic understanding of research methodologies, but there's a lot of stuff that goes over my head. But that's kind of understandable. There's nothing to stop me putting my hand up and saying, what does that mean? Which I hope to do in the future. At this point, I guess my role in the committee has been very much as a sounding board from a consumer lived experience perspective. But hopefully, as the centre goes forward and progresses, I'm hoping that there will be more opportunities for people like myself to play a larger role. I do it as a volunteer. It is my way, I think, of giving back to institutions like this that have done so much for me, and indeed for people with prostate cancer. So I really look forward to that opportunity to play an expanded role as a lived experience advocate here at the Peter Mac. So again, I might close it there, I think, but I just want to thank everybody, and please encourage all of you, if you're involved in committees, think about people like myself, the lived experience, and what we may bring to your committee and how it may actually make the end product much more effective than perhaps it would have otherwise been. So thank you very much. Thank you.
Thank you very much, Stuart. I think, welcome everyone. My name's Ricky Johnson. I'm the Executive Director of Research here at Peter Mac. And I just wanted to reflect a little bit on Stuart's presentation there. I mean, the first thing that came across is that it just dripped of passion. You know, passion for what he does, how he lives, how he thinks. And, you know, you can't replace that. That's something that comes from within. And I think it's so genuine and so authentic. It actually is really inspiring. The second thing was his commitment to, you know, living the best life that he can and to giving back and to helping us actually and being part of the team. And your advocacy and others, our other consumers at Peter Mac are the things that I think help drive us every day. At this moment, I'd just like to give a shout out to a few people who have really driven our consumer engagement program. Anna Jones and Alison Ogden. They've helped drive the Research Consumer Registry to more than 300 members now. And that's something that just doesn't come about. Again, there's passion and commitment from that team to bring that about over the last few years. And it's something I think that, you know, we should be rightfully proud about because, you know, we are truly now in the best way engaging with the public, with the community, with the people that we really want to help. And it is coming back. There is this bi-directional flow now that is really, I think, so very important. To Kaz, congratulations, Kaz. It's been a long journey, and to you and the team, you've really, I think, built out a wonderful team now, and it's just the start, is just the tip of the iceberg, I guess. Kaz has done a fantastic job on educating people like me who are researchers in different domains, and understanding what health services research is about. And she mentioned the other associate directors. I think we've all been on this education journey and we're really getting it. And the more I learn and the more that we learn, the more we understand how important and terribly important this is. Rosemary mentioned bench to bedside. There's another component to that, and that's bench to bedside and beyond. And this is where health service research plays a huge role, a massive role in the beyond part. And we're thinking about, you know, value-based healthcare and how we're actually going to deliver that. It's got to be evidence-based. It's got to be based on what we understand, how we can articulate that and measure it, and then how we can roll that out. And I think that's going to be a major part of what this centre will bring. And it's a key component of the new research strategic plan. We think about our translational pipeline and we often think bench to bedside. We're making discoveries in a lab, we're driving that into the clinic, we're driving new clinical trials, but it's got to be more than that. I think what we really have to do is think about translation in terms of policy development and national reform, in fact, international reform, and it's got to be evidence-based. So that's where this centre is going to be so important, and the people within it and the platforms within it and the programs within it are going to be so incredibly important to add that dimension to Peter Mac research. So again, congrats, Kaz, you've drawn a crowd, and hello to your mother online. You should be very proud of Kaz. And so now it's my job really to ask the panel members to come up here. We'll have a short discussion. So that's Janelle Lolinger, Belinda Campbell, Belinda Lambros, Craig Connolly, Kaz herself, and I will help herd the cats and mediate some discussion. Okay, so we'll have some discussions that I'll start off with, I think, but then we'll go to the audience for some. And I guess starting with you, Belinda. So you've previously been a Mac Health Services Research Future Leaders Fellow, and you're midway through your PhD. That must be fun. Tell us about the methodologies that you've utilised through health services research and how that's helping you with your own research program and your PhD.
Yeah, fantastic. Thank you. Thanks, Ricky. Just to for people who don't know me, I'm a clinician and I've pivoted from clinical research into health services research. And you would think that should be easy, okay, but actually it's an intergalactic leap. I am learning a new language, new methodologies, new questions, new indices. Everything's a steep learning curve. It's super stimulating. It's really been very invigorating to my career and my research career. And I'm very grateful, as Ricky said, I was Peter Mack's first, let me just catch my breath, hang on. I was Peter Mack's first Mac Health Services Research Fellow at the Melbourne Academic Centre of Health, which is a superb program, super supportive. And from there, I've been able to continue now on a PhD journey in the very supportive surrounds of this team of people in the Health Services Research Department here at Peter Mac. And sorry, I'm getting to your question in a minute, Ricky. But first, well, first up, Kaz, I was just going to give credit to you. So before I do that, whilst I've got the microphone, I'll keep talking. You can wrestle it out of my hands later. But I just wanted to say that I was very fortunate that I landed, or I was assigned Kaz as my mentor on my Mac fellowship. And I caught her bug. Like, she's an infectious diseases physician. She knows about contagions, right? She's very clever. And it's this energy and drive, and it's super motivating, and you want to be part of it. And it's a wave of momentum. And before you know it, you've signed up for a PhD. It's fantastic. So thank you, Kaz. Yeah, I'm very lucky. Anyway, getting back onto my PhD and my research methodologies. So it's quite diverse, which I'm gathering is the way it goes in health services research, which means the learning curve is steep and continuous, and really that's exciting. My first project in my PhD involved epidemiology and looking at, I wanted to plot heat maps of what I'm studying, which is cutaneous T-cell lymphomas, and I wanted to plot that across Australia. So with fantastic collaborations in place, we were able to do that and really investigate not only where these patients are residing, but also looking at indices like socioeconomic areas of socioeconomic disadvantage and areas of remoteness. And this is important data, I think, because it forms a platform to look at healthcare provision and the equity of provision of that care across Australia, but also looking at geographical based etiological factors and other factors that might be contributing to who's actually getting diagnosed and where they are. So that was my first project. My second project has been looking at healthcare utilisation, in my case radiotherapy utilisation in my target population. And this has been a really fantastic, I've just been so lucky to link up with people with this data linkage that connects the Cancer Council data and the radiotherapy utilisation data across New South Wales, which has been fabulous. And I've been able to look at the geographic distribution. Oh, literally crickets. Yeah. I'll keep going. And so that's been really fulfilling. Well done, well done. Oh no. Yeah. Anyway, so I've been looking at geographical disparity in the use of radiotherapy utilisation in my target population. And I came into this research project with some pretty firm preconceived ideas as a clinician of how this was going to play out. And as it turns out, I was completely wrong, which goes to show how important health services research is, because if I've just gone ahead and implemented something without doing the research, and on that note, I should also make a special shout out to Tim Spellman. I'm not sure if it's here or online. He works in the Health Services Research Department here, and I can call him and ask him my questions. You know, what statistical should I using what's the most appropriate thing. He's a very clever man. He's multilingual. He speaks statistician and non-statistician, which is
Always helpful.
very helpful. And my next project, which is currently underway and yet to be, finessed, but I've spoken to so many people. But what I want to do is really understand, with consumer involvement, really understand the patient priorities and how they are choosing their healthcare decisions, how they're making their healthcare decisions. And so I reconvened with Cass last week, and she's like, "What these ninja moves?" I call them ninja moves. And so now I can see the forest for the trees again, which is excellent. And I look forward to collaborating with board and Chen and other members of the AHR.
Wonderful. Thank you very much, Belinda. It's fantastic. Sorry, I'll go to Belinda now. Belinda, you've just started your PhD in sepsis, and I just wonder about, how it's going for you to start with, and really how the centre will help facilitate your own PhD.
Good luck. Thank you. So my name is Belinda Lambros. I'm the nurse practitioner with infectious diseases and antimicrobial stewardship. And last Friday I received the email to say that the Uni of Melbourne were finally getting on board, and I'll be able to start my PhD very soon. Thank you. It's, I guess, congratulations, but also commiserations, because it's a little bit scary. But who would have thought a high school dropout would actually get to this point? And I think part of that is because of hard work and dedication and support from a team, and health services research really is where it's at, as far as I'm concerned, for nursing, because we very much are at the bedside. We are the coordinators of care, both inside the hospital as well as supporting the patients to navigate the system. And that's where my project, I guess, will be, and it's going to incorporate the whole components of health services research, because the first one will be looking at that data. We've already been looking, and we have a great 5 years worth of data for the patients with sepsis, so we can have a look at their outcomes and when they have been readmitted, because we know that at least 30% of these patients do get readmitted with an infection within the first 90 days. And so to be able to look at those patient outcomes, look at how the sepsis pathway has supported them through, and what happens to those patients if the sepsis pathway isn't followed compliantly as well. But then moving on to those patients after their hospital admission is where my project will come into fruition, because we know that these patients need good education, they need good support to make sure they either come back to hospital early or are able to not need hospital a second and third time. And health services research will bring in that co-design piece for us, because we need to know what the patients and their carers need in order to support them in those programs. So the first piece, I guess, is that data analysis, which Tim will be helping me with, as well as Daniel. I saw Daniel in the room. Thank you very much, Daniel, and I apologise for all of the questions you will get. And then the second piece really is that co-design, and then looking at implementation and how we can support these patients, carers, and the community as well, because it does need to be a shared care piece with the GPs, with the physios, with the cardiologists, with the renal physicians, with the infectious diseases physicians, and making sure that the patients are able to be supported in the community as well. So the whole team is going to be helping me, and they're probably going to be sorry that I signed up.
Janelle, as head of the Allied Health Department here at Peter Mac, how important is it for you to have this centre now as a place for your research and your team to flourish?
Thanks, Ricky. My name's Janelle. So I'm the manager of nutrition and speech pathology, but here as a token representative of allied health. And look, it's a great question. I think for allied health, let me just give you, I guess, some context. We're made up of 11 different disciplines. So that ranges from dietitians, speech pathologists, physios to music therapists, social workers and spiritual carers and more. I'm not going to list them all. We are diverse. We're diverse in skills. And so obviously we're all trained as clinicians to work in the environment with people with cancer and their carers. And we do that really well. From a research point of view, some of us are interested in research. So I have since enrolled in a PhD part-time, which I'm doing now. But that's only come after working for 20 years as a dietitian and as an operational manager. But there is so much scope and opportunity within allied health to expand what we do. I think to date we have done a lot, probably with very little resource. And, you know, there's outstanding leaders like Jackie Frowen. You know, we've got support from Linda and Lara and Elizabeth, who have been our allied health dedicated researchers, built, you know, and embedded within our health services research team, helping and supporting allied health to grow and build over many years. And I think, I guess, speaking to the diversity of the disciplines that comes from allied health, and I'd like to also acknowledge the other colleagues that we work really closely with in our psychosocial teams, in pharmacy, in cancer imaging. There's so many people across the organisation. Allied health work across all tumour streams, within all treatment types, at all time points of a patient's journey. And so I think the opportunities are enormous. And I think we have tapped into many people within health services research to date, you know, in terms of help with methodology, with stats, with implementation science. Like there is so much more we can do with a coordinated effort, I guess, moving forward with this centre. So we're really excited about forging a clearer pathway for allied health professionals and others to build capacity, to actually dive in and learn more about research and embed that within our day-to-day clinical work, because I think we can have an enormous impact on how quickly we can translate research into practice if we are embedding and all working together in a really clear, cohesive way. I think we've got a lot to do in EPIC and building our capacity, you know, making sure the right data is going in so we can pull the right data out. And I think that will directly inform our models of care. It will help us embed the vast range of work that our allied health clinicians and researchers are doing already. And embed things like, and I'm going to give a plug for nutrition, but nutrition and exercise have been shown as interventions that can improve survival, that can improve treatment completion, that can improve quality of life. We don't embed these things as part of it. They're not expected as part of care, and they should be. And I think what we can achieve through this centre is really, you know, enhancing the outcomes that, you know, and really demonstrating the outcomes that we know exist, and embedding those into care every day.
Thanks, Janelle. And you can just see the momentum that's building when we've got, you know, such wonderful, you know, PhD students now embedded within health services research. I'll now switch over to Craig Connolly. So Craig's the new Chief Executive of the Peter MacCallum Foundation, and Craig's been drinking from the fire hose since he started here at Peter Mac. Craig has his own lived experience with cancer, and he can talk about that in a second. But I'm interested, Craig, I guess, in your own reflections around health services research in the centre and what it can bring, and then how it could resonate with our donors, and in your thoughts around that.
Thanks, Ricky. And firstly, Kaz, congratulations. I didn't realise the extent of the journey, but this is clearly a milestone event for you. So I just want to acknowledge that. Janelle, I'm going to reflect on your comments at the end there. So I had leukemia 20 years ago, I was flown back from Canada with leukemia and straight into the Royal Melbourne into 39 days of isolation. And in day 2, I had a bike brought into my room, and every day I got on the bike. And I was lucky I was very fit at the time. So I really can resonate with some of your comments. But I also had 6 weeks, 2 separate stints, 6 weeks in total in ICU because of golden staph, sepsis, and related infectious diseases as well. And I now know what's known as cachexia. So I was very ill. And my journey was with predominantly allied health professionals. So as CEO of the foundation, I think people in the room should understand you have an ally in me. That's the point I would make. In terms of how I think about how we can help all aspects of research and work undertaken at Peter Mac. I wrote down 5 points that are reflecting on the Health Services Research Centre, which I'll be very quick about. Evidence-based, community-led, equitable, patient-centred, they tick a lot of boxes with a lot of funders, is the first point I'd note. I think about the term intersectionality when I think about Peter Mac. This is actually not a health services specialist organisation. It is an organisation that deals with community intersectionality. We have people coming in and we have to treat all aspects of the person. So the fact that this is patient-centred as well allows you to talk in a way that broadens the audience you can talk to with donors and prospective donors. Donors like the concept of their money having what we might call translational impact. So health services research facilitates that translation and that impact. That's the next point I'd make. And the last is systems thinking can only occur if you have specialists who are thinking about analysing and influencing the system. And absent health services research, I struggle to see how any institution can do that. So this is a really important value add to Peter Mac, again, from a donor's perspective. And the final point, and this is where I've been drinking from the fire hose, but 49,000 patients are treated at Peter Mac every year. We have one of the largest laboratory and clinician-based research capabilities in the country, and they are focusing on assisting in the research-led care of those patients. So if you want to achieve systems change, you need to work in an institution that is an integral part and a critical component of that system. That's what Peter Mac is, and that's what makes it unique. Not many donors understand that, and that's where I'll finish. Thank you.
Wonderful. Okay, so we're running a little short on time, and Kaz has very kindly offered to give up her slot to speak so that we could have maybe 1 or 2 questions from the floor. So very happy to take one. John.
It's not a question, it's actually a compliment. And I just want to say how important this development is from my perspective, working at MAC, which is about translating research into improved care. We heard from Belinda Campbell that she was in our first cohort of MAXA fellows. This is about getting frontline clinicians and consumers together to solve problems through health services research. Thanks to Jason and to Shelley and other CEOs for supporting it. Thanks to Kaz for being one of the academics that supports this. All done for free. This is self-funded. The reason this is important from my perspective is that on Monday we have a paper being published, the title of which is Health Services Research as a Frontline Clinical Service. And our thesis is that it's only if health services research is mobilised to the front line where consumer meets clinician that it becomes maximally powerful. So what I see in this fantastic initiative is making that concept real. Health services research at the Peter Mac is now part of frontline clinical care. So I compliment you for doing that.
Hi, I'm a bit nervous about speaking, but okay. My name's Anna. I'm a very proud member of the consumer panel here. My husband died nearly a year ago and 3.5 years after his cancer diagnosis. Although huge strides have been made in cancer treatment, The experience of cancer is long and up and down for many of those with a cancer diagnosis and those who love them. Rather than a question, I'm keen to highlight the ongoing care of cancer patients, including the many who will not survive their disease. Okay, that's it. Thank you.
Thank you, comment on that.
You're so right. You know, we need to recognise there is a journey. It's not only just the patients, but also the carers and their families, and everything that we do around. It's not just patient-centred; it's also patient carer centred, and it's a central driver for how we are going to properly implement these programs of care through the whole journey. And you know, we have an amazing psychosocial oncology research group here that are also working, who are working with us. So we are multidisciplinary. We hear your stories, and we have amazing consumer researchers that have been very clear about what they want and what they need, and they're integral to how we have designed the centre program. So thank you for your comment.
All right, thank you for that, Kaz. Look, I think we should finish up now, and just remains to thank our wonderful panel for your comments. Thank you very much. And can I please introduce the Peter Mac Chief Executive, Professor Jason Payne, to conclude events.
Thanks, Ricky. Wow, what an event. Absolutely terrific. And I'd like to thank all of our speakers and our amazing panel today. Ricky actually stole my words. I was thinking about what encapsulated all of those speeches, but it was actually passion and commitment. And everybody that spoke today also had this amazing vision about what the future can look like. So it's a very exciting time here at Peter Mac. Thanks to Kaz. When I first started, Kaz and I had a coffee and discussed the centre, and I was sold on it from the first conversation. This is something that I'm very passionate about, and I've always really wanted to be a part of, and particularly participate. And in fact, in one of Kaz's, I'm sure, many applications for funding, I was also nominated to be part of a project. So this shows me that everybody can be involved, and we could see the broad breadth of the multidisciplinary team. This carries interest from, you know, our board to the executive, to the clinical staff, to the research staff. This is something that's really holistic, and something that I can see can be really transformative for Peter Mac, for the patients that we treat, for the body of research and our community. So absolutely well done. So I'd like to thank everyone for attending today. I'm very conscious of time, and we do have some lunch waiting for you out there, so we can continue to do some networking and to enjoy each other's company. But I'd like to thank you all for coming. I can see that there's lots of different partners in the audience today that we look forward to working with over the coming years to achieve really outstanding results. So thank you everyone very much.